So welcome, thank you all for being here. We're so excited that so many people were interested in both learning about this topic and also hopefully coming and sharing your perspectives on the topic of perinatal substance exposure. It's a very important topic in our community right now and has been for a long time. My name is Robin Schurig. I'm the Public Health Director for Shasta County. I'm going to go through some housekeeping, and I'm going to share some of what we've been doing, what our staff has been doing to gather information about this topic and kind of what we're planning on doing next with all of the information. And I'm also going to share some data around why this topic is so important in our community and what's going on out there right now as far as what the data tells us. But like I said, we also want to hear from you about what you're seeing in your professions and out in the community. So I'm going to start with, let's see, I want to let you know that we are video recording the presenters. So you'll see the cameras faced up here. So the people at the podium here and at the table when we do our panel presentation are being video recorded, but we're not going to be video recording the audience. So don't worry about fixing your hair and makeup out there. You won't be on camera. This is a statement that I need to read verbatim with regard to the CEUs. So I'm going to just go ahead and read it right from the slide here. None of the presenters, planners, or others in control of content for this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. There's some more disclosure information on a sheet on each of your tables outlining additional information about CEUs if you need that. I want to give a thank you to some of our sponsors and partners who've been helping us put this together. So first we want to thank the Opioid Response Network at UCLA. They're the ones who are providing funding for Dr. Stockton to travel and speak with us today, as well as the free CEUs, so big thank you to them. First Five Shasta, along with Shasta County Public Health, are co-hosting the lunch and refreshments. And First Five also has their executive director, Wendy Dickens, here, who's going to be facilitating our panel discussion today. So thank you to First Five and to Wendy. The Shasta County Office of Education obviously is providing the space for us today here, and they also are providing technical support, other duties as assigned. Along with their staff member, Joy Garcia, who's going to be facilitating some of our activities both today and on a virtual session that will be offered on March 16th. We'll tell you a little bit more about that. If you have coworkers who weren't able to make it here today, there is going to be a virtual option available as well. So thank you to Scully and to Joy for those contributions. We also want to thank Dr. Stockton, who's our keynote speaker today, as well as the participants on our panel. We'll introduce them a little bit later, but we really appreciate them coming and sharing their expertise with us today. So why are we here? Why pay attention to substance use during pregnancy? Shasta County has some of the highest rates of substance use during pregnancy in the state, and I'm going to go over some more specific data in just a minute to demonstrate that, but obviously that is a problem because babies who are exposed to alcohol, tobacco, marijuana, or illicit drugs in utero can have not only lifelong physical, emotional, and or developmental problems as a direct result of that exposure, but also children who grow up in families where substances are used tend to face other adverse childhood experiences as well. They're more likely to encounter abuse and neglect, incarceration, parental separation, those kinds of things that impact the way that the child's brain develops. So the Public Health Maternal, Child, and Adolescent Health team has been doing what we were referring to as a deep dive into perinatal substance exposures. And they've been collecting data and information. They've been mapping what the current systems look like, as well as trying to identify gaps in the system, as well as barriers to accessing existing systems and services. They've also been engaging with cross-sector stakeholders, partly through today's event, this summit, as well as the virtual option on March 16th, but also through a task force that's been meeting, and I'll tell you a little bit more about them in just a moment. And then our plans following this are to produce a recommendations document by the summer of this year. And so we'll be able to share that with all of you for you to, inform work that might be done within your organizations or to help you apply for grant funding and those kinds of things, as well as to inform our work within public health. I want to ask the MCAH team to please stand and wave so that people can know who you are. If you have any input that you want to share with us, these are the folks to speak with. I saw one person standing in the back. There we go. There's a couple more. Thank you. Look around the room. We got people standing and waving. That's our MCAH team. So they've been doing all of this work leading up to this and planning for today's event. And they do want to hear from you. If you have ideas that you're not able to share during today, you're welcome to just, or if you're not comfortable sharing in a group setting, that kind of thing, you're welcome to just speak with any one of them individually as well. All right, so our task force that I mentioned, this ad hoc task force on perinatal substance use, has been meeting since January, and we want to thank this group of passionate and committed individuals. This is their list of names. I won't read it to you, but they've been coming together to learn and strategize together We all recognize that perinatal substance use is too big of a problem to ignore and too big and complex of a problem to tackle in any one organization. So it's really important that we're coming together to try to identify strategies and solutions. This next list is the organizations that those task force members represent. So a thank you also to these organizations for allowing their staff to commit time to this effort. And we have a wide variety of different partners there represented. So I wanted to share that information with you as well. So moving on to why now? Why is this topic important to address now? And obviously, as we'll show in the data, this has been an issue for a while, but it's been increasing. But there's also been some changes that have happened recently that have led to some of that increase. So one of them is that fentanyl has arrived in Shasta County, and it's not just Shasta County, it's everywhere, but it is here and it is pervasive. We've also witnessed the legalization of recreational marijuana, which has increased obviously the availability, but also the normalization of marijuana, right? People are thinking that, oh, it's legal, it must be safe, it must not be as harmful as some of those other harder drugs, and so it's being more normalized, especially among our young people, and we'll share some data about that with you as well. And then, of course, the COVID pandemic, which has impacted everything, but in this realm, it's impacted potentially changes in services and programs that are being offered, as well as just leading to an increase in poor mental well-being and an increase in substance use among our population in general, but also including young adults of childbearing age. So neonatal abstinence syndrome is when a newborn exhibits symptoms of drug withdrawal. So Shasta County has one of the highest NAS rates in the state, and our rate is not just a little bit higher than the state, it's 7.2 times as high as the statewide rate. This represents about 35 babies per year born in Shasta County with NAS, and those babies need treatment and often extended stays in the neonatal intensive care unit, or NICU. This, of course, is just the tip of the iceberg too, though, right? Because not every baby who's exposed to substances in utero is going to have neonatal abstinence syndrome or have impacts that are going to be detected right at birth. So there's other impacts that will show up later in life. Fetal alcohol syndrome, low birth weight, of course, happens at birth, but it's not necessarily known right then that it was because of substance exposure. There's also developmental delays that can show up later on because of substance exposure, many other impacts that aren't reflected in this number. So I'm going to dive into some data now from our community, and I'll try to explain to you kind of the source of the data and which population it represents, because there's a variety here, but feel free to stop me if you have any questions as well. So starting with tobacco use, this is specific to pregnancy, and this data comes from the Maternal and Infant Health Assessment Survey, or MIHA. This is a survey that's conducted after babies are born, and it asks women to go back and report information from before they were pregnant, during their pregnancy, and then since the baby was born. Obviously, it's self-reported, and it only captures people who are willing to participate in the survey, so it's not necessarily representative of all births, but we can at least take a look at how we compare in Shasta County to the whole state of California. And for tobacco use, our self-reported rates of tobacco use are higher than the state in every one of these categories. And the different categories, in case you're not able to read those from the back, are 3 months before pregnancy, and then in the third trimester of pregnancy, and then postpartum. So in both Shasta County and in the state, some women quit during pregnancy, and then some of those start up again after pregnancy, but all three of those categories are higher in Shasta County than in California. And the one that's during pregnancy, during the third trimester, it's 11.9%, 11.5% in Shasta County report using tobacco during their third trimester, compared to only 2.5% statewide. This next one is from that same source of data. So again, it's self-reported and it's after pregnancy, but this is asking about cannabis use during pregnancy. So anytime during pregnancy, not just in the third trimester here. And again, Shasta County is much higher than the state with about 13.7% compared to 4.7% statewide. This next set of data comes from drug treatment. So this is CalOMS data, if you're familiar with that. And this is specific to pregnant women who were in drug treatment during their pregnancy. And so what we see is that the most common substances being treated among pregnant women are in this order: meth, followed by heroin, and then much lower is alcohol. And then marijuana shows up mostly as a secondary substance. And speaking of which, polysubstance use is quite common. About 60% of women who are in drug treatment during their pregnancy are being treated for more than one drug. This next one comes from hospitals. So when a woman enters the hospital to give birth, They look at her chart, and if there's any indication anywhere in her chart of any kind of substance exposure or substance use, then it shows up in this data. So that could be a test that was done at the hospital or during prenatal care, or it could just be a self-disclosure that the woman disclosed to her prenatal care provider or in the hospital that she had used during pregnancy. And so again, this is the tip of the iceberg, because not all women who have used during pregnancy are going to be known about when they deliver. So of those who delivered in the hospital, 12% had some mention of substance use in their charts. And of those, the most common, well, polysubstance use again was quite common, but of the individual substances that were listed, nicotine was the most common, followed by cannabis, and then much lower was opioids and then other stimulants. This next one is not specific to the pregnant population. This is all overdose deaths in Shasta County residents, and this is showing 2019, 2020, and 21, and it's broken down by substance. So I don't know if you can read it in the back there, but there's many substances down at the bottom that have kind of stayed pretty flat, or maybe gone up and come back down, or gone down and come back up. But the two that are colored there, the red one is fentanyl, and so we only had 5 overdose deaths back in 2019, and by 2021 that had risen to 40. Heroin has been, meth has been pretty high, but has been increasing also. We had 25 overdose deaths due to meth back in 2019, and that is also at 40 in 2021. So those have both been increasing rapidly in Shasta County. Fentanyl more rapidly than meth. This next set of data is from Shasta College students. It's a survey that's conducted every year at Shasta College, and Shasta College students, have a wide age range, but most of the people who participate in this survey are either young adults or even teenagers, because there are high school students who are taking classes at Shasta College who participate in this survey as well. So most of the survey respondents are between the ages of about 16 to 22. And of those who say they've ever used marijuana, 98% initiated use before age 21, and almost a quarter initiated use in junior high. So that's age like 11 to 14-ish. They also, among those who reported using marijuana, it was more common for them to report at least weekly use. So those who are using marijuana are using it pretty regularly. Whereas with alcohol, while still a large proportion, 92% reported initiating use before the legal age of 21, they commonly reported using only once or twice per month. So it is, common for people of that age to be using alcohol, and most of them did start at a young age, but they're using it less often or less regularly than those who are using marijuana. So that's what some of the data says, and like I said, we're excited to hear from you today and from our presenters about what's really going on and what the barriers are and what some strategies might be to reducing substance use during pregnancy. And we know that this issue is too large and too complex for any one organization to tackle on our own, so we're hoping that by coming together as a community that we can come up with some strategies that we can either work on together or work on in a coordinated effort to be able to address this issue in our community. We want to thank our panelists and our presenter. They're going to be sharing some different perspectives on what's currently happening in the community and what barriers might be. They come from a variety of different backgrounds, so we're excited to hear from them as well as you, as I mentioned. And so I'm going to move on now to introduce our keynote speaker, Dr. Candy Stockton. Just give you a little bit of background on Dr. Stockton. She is board certified in both family medicine and addiction medicine. She's currently the public health officer in Humboldt County. She is the clinical champion for the Humboldt RISE project, which is a countywide perinatal substance use disorder project, and Humboldt County's jail MAT program. She has worked in primary care in rural Northern California, including in Shasta County, since 2006, and she sees every day how the disease of addiction affects individuals and families in her community. Dr. Stockton is active in community outreach, serving with various groups that address addiction and family issues. She has worked with law enforcement and treatment programs to increase access to Narcan in communities. She's an active speaker working to help educate community members about addiction and addiction treatment. And she's a consultant for the Hub and Spoke project in Northern California and for California's Opioid Response Network. Please join me in welcoming Dr. Stockton. Let me just show you some tips here on the slides as well. So if you click this button, it'll go to the next slide. Okay. If that doesn't work, there should be a little box up here that says resume slideshow, and just click on that, and then that should start working again.
Let me just say, first of all, that I'm really grateful to have been asked to share this space with you as you important work today. And I want to give a little kind of pre-disclosure, not financial disclosure, but if I could ask for a show of hands, how many of you are not doctors? Perfect. So anybody who did not raise your hand, you can ignore what I'm going to say next. For the rest of you, what I'm going to be sharing, the model, the paradigm of care that I'm going to be sharing today is the medical model. And it's going to be shared from my perspective as a doctor. And I also want to fully acknowledge that doctors are late additions to this work, right? So what I'm sharing with you, the model, the paradigm that's developed, is not from us, doctors, walking in as a savior with all the answers. It's with full recognition and humility that what we're sharing today is built on the back of the work that you guys have done for the last 100 years, while doctors have yelled not it and pretended it wasn't their problem. So I do want to acknowledge that where we've arrived at today is more a result of your work than of my work, and it wouldn't be fair or honest to talk about this without acknowledging that first. So I graduated from medical school in 2000 and went to residency in Florida Hospital Orlando, and in family medicine. And my exposure or training about addiction at that stage was pretty typical for what doctors received, which was something along the lines of, yeah, some people do drugs, and a lot of people drink alcohol and smoke, and that's bad. And also, some people will try to get more pain meds than they should have. And the way you figure that out is when somebody comes into your office and says they have pain, and you ask them what they want or what they need or what they take, and then you just write that prescription for them. And you tell them when they want a refill to just call back and let you know. And then when they call back, you ask them where they want you to send the prescription, and you call the pharmacist and ask them what they're filling. You know, maybe they're getting stuff from other people, maybe not. So that was the really hot, intelligent tip that one of my attendings taught me in medical school. And that was, so that was the training that I had on addiction when I left residency. Not terribly comprehensive, not terribly helpful, not much of anything, actually. So I left residency. Great. Okay, really quick, backing up. I am a local representative for the Opioid Response Network. SAMHSA funded work throughout communities to help increase access to treatment. The way they did that was by recognizing that we all have our unique set of circumstances. It doesn't really help you a lot when somebody who practices in LA comes up here and talks to you about what they do to treat addiction, because they have no understanding of our communities, right? The Opioid Response Network provides funding, has a network of technical consultants that are stationed across the country, all 50 states and 9 territories. And should you want additional assistance, you can go online to the Opioid Response Network, fill out a technical assistance request, and they'd be happy to provide that for you. And I don't have any financial disclosures. Okay, so I left residency and I came back to practice in California, where I'm from. And at that time, in 2004, to get licensed in California, you had to take an additional 12 hours of training about pain management. And I go through this because some of you who are a little younger in this field kind of wonder how we got to where we are today, and kind of wonder why those crazy doctors are so resistant about still writing pain medications, and why are they doing that stupid stuff. So the background is kind of important. So in 2004, when I came back to California and got licensed here, I had to take 12 hours of training in which I learned about the California Pain Patient Bill of Rights, with the mandatory requirement that it was a patient's right to receive opioids when they were in pain, and that failing to do so opened me up to both malpractice claims and potentially criminal liability as well. And in addition, the answer to, okay, but how much is safe, is however much the patient needs to feel like their pain is relieved. So this was not just something that doctors came up with on their own. This was actually mandated by law. And being trained in this was actually required, and continued to be required, I think, until
2012, 2014, somewhere in that time frame. So there is a reason that doctors in your community have done the things that they have done. It was at that time what we were required to do. So I got out here, I briefly joined an HMO group in Southern California. I figured out pretty quickly that urban lifestyle was not for me, and I relocated back up to this area here, actually. I lived in Shasta County, but I worked at Trinity Community Health Center up in Trinity County. And it did not take me very long to figure out that the patients who were on pain medication were my worst patients. Oh my God, they were the worst. I would have been hard-pressed to tell you why they were the worst or to define why that was, but they were the ones that just left me exhausted and worn out and wondering why I do this work at all. Because of that, and because of some other things I was noticing in my practice, so for instance, I show up at Trinity County, and this is like me barely, 29 or 30 years old at the time, and I show up, and I'm really eager to be part of the community, so I make the rounds of all the local business owners up in Weaverville. And I'm at one of the businesses, and I will not say which one because it doesn't really matter. And this lovely young gentleman walked up to me, not recognizing me because, again, like a week in town, and said to me, "Hey, would you like to buy some Norco?" And I said, "Norco? Really? Can I see that?" And looked at the prescription bottle and realized it was written by my clinic. Right, so I had some early indicators that maybe this was a problem. So in 2008, when I moved to Shingletown Medical Center, I looked for some guidelines around, there must be some rules around this, some guidance around this, around how we should be prescribing or what we should do. And in 2008, when I did a literature search for any professional guidelines that were available around managing pain medications in patients, I found one. There was one. And it was that you probably shouldn't write more than 100 milligrams of methadone a day for a patient for chronic pain without consulting a pain specialist. That was it, nothing. Urine toxicology screening wasn't readily available and people didn't use it. So that was the extent of what was available. So I thought I'll write my own guidelines, and I instituted a practice of actually kind of urine toxicology screening was just becoming available in hospitals or in office settings then, so I started urine tox screening. We set some guidelines about how often you had to be seen in the office and what you had to do, some really pretty basic stuff. And within a couple months of implementing that, not only was I getting death threats from patients, but my board was almost ready to fire me because they were afraid it was going to cut into our patient visits. And the local doctors were telling me I was A, crazy, and B, that was unethical. But I had really strict policies. Like, if you didn't test positive for the drugs we were prescribing for you 3 times in a row, I wouldn't write those drugs anymore. Really, really strict, right? Like so mean. And it is surprising, though, what patients will tell you if you just ask them. So I would ask things like, "Hey, do any of your friends buy Norco on the street? How much are those pills?" Right? So I calculated in the first round of patients that I quit prescribing for, there were 6 patients. And I calculated the street value of their prescriptions on a monthly basis based on what my patients had told me you could buy pills for in the community. It was over $100,000 a month, street value. Yeah, they were making a lot more than I was. So those things kind of combined together led me to believe that there might be a problem with the way we were prescribing pain medications. Might. And so when the opportunity came up in 2009 for me to get trained on what I will call buprenorphine, because that is the generic name, but what most of you probably know as Suboxone, and was only Suboxone at that time because that was the only manufacturer available. When the opportunity came up to get trained on this, I thought, I'll do that. That sounds like that would be a useful tool. So the you'll love this. The drug company paid for us to go down to Sacramento where they hosted a training on how to do this, and we got our mandatory hours so we could apply for our waiver. And I learned really useful things. Whoops, I'll go back. I learned that basically everybody who takes opioids is probably addicted to them. And it's okay because we have this cool medication, and you're just gonna like make them go to counseling and make them drug test and treat them for like 6 months, maybe 12, but probably 6 months. And then you're gonna taper them off medication and everything will be great. And I was like, cool, problem solved, I got this. Kick back at the beach, enjoy myself. Oh, and by the way, some people just aren't ready for change yet, and they'll have to hit rock bottom before they're ready to come back and change. So, but I got this, right? Problem solved, it's 2009. I've kicked this problem, I'm ready to go. No surprise, that didn't work. So in 2013, there were a lot of other people that were starting to actually think maybe this is a problem. And Ivan Petrozalka, a local pharmacist and lawyer, started No RX Abuse, Shasta. I don't know how active they are anymore. But at one time, back 10 years ago, we were very active, and I was one of the kind of original core members of that. And we did things like getting reports from the state about what doctors were prescribing a lot of opioid medications and talking to them about that. We did, we applied for early grants to get Narcan placement. I think I did the first trainings for law enforcement officers locally when they started carrying Narcan. So these were some important things we were doing, and we viewed this as primarily a problem that was within the medical system. Doctors were writing too many pain medications, people were abusing them, and that was really the problem. And so if you could teach doctors not to write too many pain medications, and we didn't know how much that was, by the way, but just if we could get them to stop writing so many, people would quit being addicted and the problem would be better, because apparently nothing exists outside of a doctor's office. So it wasn't until 2014, the end of 2014, that the California State Medical Board actually came out with guidance about what was considered okay for opioid prescribing. And they did some work that was really important in terms of kind of setting some guidelines for how you should move forward with people who are coming in with chronic pain. But they did a crap job actually considering what we do with people who have already been on opioids long term. Right? Because being on opioids long term, whether you're abusing them or you're taking them for cancer pain or whatever reason you're taking them for, they change the way your brain works. And you can't just suddenly erase that change. But we're doctors, we can do anything. So of course we can suddenly erase that change just by changing our guidelines. And then in 2015, two things happened that really shifted the course of my career and my understanding of addiction. So the first was that Dr. Thomas Perry, I don't know how many of you remember him. I'm not sure if he's still practicing locally.
He is.
He is? Okay, so this is his fault. The fact that you're listening to me today is his fault. He came up once a month to Shingletown, the clinic that I ran, and did gynecology consults for us. And he was practicing OB down here in Redding, and he had a patient who was pregnant who moved to the area. Now, in 2015, we did not have a methadone clinic in Shasta County. And I believe we technically had 3 providers who had a buprenorphine waiver, but nobody was really doing it, and certainly nobody anywhere across the state was really prescribing for pregnant women. But he knew I had a waiver. I had quit using it at that point because, unsurprisingly, my patients were not getting better in 6 months. They weren't magically quitting using drugs, and they were having their mothers forge notes pretending to be drug counselors, say they were going to counseling. and that just didn't seem to be working for me. So I'd pretty much quit using my waiver, but I had one. And she moved here from a county, his patient moved here from a county where she was actually able to get buprenorphine while she was pregnant. She was on buprenorphine, she's only a couple months pregnant, moving to the area. And he said, you got to take this patient. And I said, no, I don't. Because, and it's funny, this is not much of a secret anymore. Most people who've heard me talk know that I actually despise OB care. I had the worst god-awful experiences in residency around OB to the point where I would still cry when I try to talk about my experience as OB in residency. And the thought of dealing with pregnant women and that responsibility, quite frankly, terrifies me. There is nothing I would rather avoid than a pregnant woman, except for potentially a pregnant woman who also has a substance use problem. Right? Those were the two things that if you asked me what I did not want to do in my life, those would be the two things I would tell you. No pregnant women, no substance use disorders. Well, I would have called it addiction, but just don't give me either of those. Anything but that and I'm fine. Anything but that and eyeballs. I also don't like eyeballs, but that's an entirely different story. And he said, but you have to, nobody else can. And there is this thing in rural medicine that family practice doctors do regularly, right? There are any number of times where a patient has a problem that is more complex, that is outside of our scope of ability to deal with, that we don't know how to treat. But there is nobody else. And so you either suck it up and get out a textbook and do your best, or the patient dies. Because there is no other access to treatment if you don't do it. And it didn't take Tom very long to wear me down. And eventually I said yes. I'm still not entirely sure why. And it was probably a bad idea, but I did it. And from this patient, who I will call Sally, I learned the foundations of everything that I use now. And I am so proud to say that Sally still sends me pictures of her kids. Not one, but two Butte babies. And I get to watch them grow up and play school sports and do all these amazing things. So to the best of my knowledge, in 2015, her baby was the first Butte baby delivered in this county. Hospital had no idea that she had substance use problems, even though she listed her medications, because we weren't even drug testing for buprenorphine at that point. The nurses didn't know what it was, even though she disclosed it. I coached her through taking her meds to her with the hospital and continuing to take them during pregnancy. And I wrote her a nice letter to keep in a sealed envelope in case anybody called Child Welfare Services on her to tell them how to get a hold of me so they could talk about her treatment. And she slid through the system. Nobody even noticed. She did well because I'm a primary care doctor. I watched her and the baby in follow-up. I've followed the baby for years. They did great. And I thought, maybe this isn't so hard. Maybe we should figure out how to do this. So that same year, I was also accepted into a fellowship program through the California Healthcare Foundation. They do a healthcare leadership program. And one of the main components of that is this 2-year, what we call a CHIP. And those of you who work for the county, it's not the same community health improvement project process that you have to go through, but it is somewhat similar. And so we knew about this CHIP before the class started, and so I showed up, and some of you will actually remember having these conversations with me. Before I went, I thought about it, and I thought, there's a problem here. There's no access to treatment for women. I can treat women. I am going to design this system, and everybody in the county is going to send their pregnant patients to me, and I'm going to do this, and I'm going to create all these forms so you guys can do all the work of collecting all the information I need so I can be efficient about it when they show up, and it's going to be perfect. Like, it's just perfect. Now, never mind that I'm located in Shingletown, and most of the patients aren't, and that I'm one person, and, but it's going to be great. So I show up there with my project, and it's all lined out, and I've already talked to many of you guys about it in the county, like, this is what we're going to do, and we get there, and they say, okay, now, some of you will have already developed plans. I'm like, I did. And they look at us for a minute, and they're like, okay, so tear them up and throw them away. I'm like, but my plan is perfect, right? I thought about all the possibilities. It is perfect. And they said, you guys tend to show up here thinking you have the answers to everything. And you have such a narrow focus on this. So your job is to go home and spend 70 hours interviewing people in your community who are affected by this problem, who do this work, and in those 70 hours, those 70 one-hour interviews that you're supposed to do, you can't talk more than 20% of the time. You need to listen. Clearly not my strong point. But it was really earth-shaking for me because I thought, oh my God, there's this new problem in the community. There are these women who are using drugs, and sometimes they get pregnant, and they need medication, and no one is doing this work, and I have to fix this problem. I'm sorry. I apologize. All I can say is that's the way I was trained. I was very, very blind. And so going out and talking to people and hearing about all the work that was already being done in the community, everything that you guys were already doing, and having to listen to that led me to understand that probably a system that involved me being like the personal savior coming in and fixing the problem for everybody was not going to be very effective. I also learned that most of you weren't comfortable with the idea of medication-assisted therapy for addiction at that point. It just was not commonly accepted. It was very much seen as replacing one drug for another, or a crutch that people used until they could really get clean. And so, I mean, this was what we all believed at that point. And so I came to the conclusion, okay, I listened to your conclusions, that this was a problem that was more complex than maybe I thought it was, that there was a lot of work to be done to get people comfortable with the concept of medication treatment before we could even talk about treating pregnant women, and that we needed to figure out how to do these things and not set up a singular point of care where all pregnant women could come to. So, along with this, the CDC finally jumped on board about a year and a half after the state of California released their own pain management guidelines that were different than California's because we love to make things confusing. And then in 2017, as part of this kind of evolution of my project, we developed a local X-waiver group. And this was, and I'm going to forget some people, I apologize, it's been a long time. So this is like Doug McMullen at Shasta Community, Donna Holscher, who was at Hill Country, I think, at the time, Paul Scipione. He was with the pain management group at the time, but I think he was also doing some addiction treatment at UIHS or at Indian clinics here, and Greg Greenberg, who was an ER doctor, along with a number of other nurse practitioners and PAs who at the time couldn't prescribe buprenorphine but were kind of involved in some of the processes. And we met on a monthly basis and had dinner and would talk about cases and treatment as we sort of built our local programs. And by the end of 2018, through that process, basically every FQHC in the county had some form of a treatment program and prioritized pregnant women in those treatment programs. Because once we got used to doing the treatment, it was a really easy lift to see why pregnant women needed to be at the top of that list, right? And I was like, problem solved, right? We did this. We can now treat all pregnant women. Babies won't have withdrawal. And by the way, that whole need to hit rock bottom before some people are willing to change, like rock bottom is death for a lot of people. So maybe we need to rethink those policies a little bit, but I got this. I also need to point out that you probably got that my last picture was like kicking back and relaxing on the beach. My husband said I have to explain that this is also me relaxing on the beach. This is me swimming with whale sharks. Coolest experience of my life, and also something I'm now dedicated to getting into every presentation that I ever give. But this is me relaxing on the beach. The last one didn't really do it for me. I was just going to sunburn there. Yeah, so like 5 years ago, problem solved. We completely got this. We've got these programs worked out. We take pregnant women. It's just a matter of time until we're all good. So what did we miss? Where did we go wrong, right? And in hindsight, it's really easy to see what we missed. The first is that substance use disorders are a chronic disease. These are, like all chronic diseases, something that people live with. They're complex. They involve multiple predisposing factors, and they involve a whole system of responses that are needed to manage the disease over the course of somebody's life. How many of your patients who have a substance use disorder relapse or slip up in their treatment over the course of any given year? About 2/3 of them, realistically, which seems really high until you ask me how many of my patients with hypertension relapse in the control of their disease over the course of the year? How many of my patients with diabetes lapse or lose control of their disease at some point during the course of a year? And the answer is about 2/3, right? Because it's hard work to do something all the time. And life gets in the way of it, and your disease will slip out of your control a little bit. And it'll look like different things at different stages and depending on what disease you have. But we know that in any given chronic disease, about 2/3 of people will lose control of their disease for some period of time over the course of any given year. Addiction is the same, right? The other thing that we just really didn't take into account is that when I say addiction is complex, chronic diseases are complex, I'm going to just kind of hold up diabetes, which is a disease at least most people have some familiarity with, and substance use disorders as really close mirrors for each other. They both involve our environment and our society. They involve our genetics. They involve our epigenetics, which is the way that this expression of our genetics changes in response to severe stress in our environment. They involve the exposures that we have before we are of an age where we can reason and respond and consent to things. And they both, to a very small extent, involve the personal decisions that we make. But that's only a tiny percentage of what actually predisposes us towards having those diseases and affects how severely those diseases are expressed in our life. So for instance, when you take a child who's developed in a high trauma environment, whose brain is different because of that, right? They are more likely to keep coming back to substances when they experiment with them because the substances make them feel a little bit better in ways that they don't if your brain was allowed to develop normally. Can anybody become addicted to drugs? Absolutely, right? Do you have to have had a bad childhood to become addicted to something? No. But you're so predisposed to it if your brain grew up in that environment because your brain doesn't feel right. Its chemical balance isn't right. And taking drugs, substances, to some extent, even if it's not a good long-term solution, temporarily corrects that chemical imbalance in your brain. So of course you're going to be drawn to something that makes you feel more normal. We all are drawn to things that make us feel more normal, right? Most of the time. So these are the things that we missed. We just didn't take these into account. We didn't understand these when we were talking about this. So now what do we do? Now if we accept this, what do we do? And the answer is, I know how to take care of pregnant women that have chronic diseases, right? It requires a complex mix of the best evidence-based medical care for the condition they have, along with the supportive services that are necessary to help them manage all of the other factors that contribute to both the development of the disease and in the way the disease affects their life on a daily basis. This is true for diabetes, it's true for hypertension, it's true for thyroid problems, depression, substance use disorders. It's all the same. How many of you have heard the term born addicted to drugs? I'm going to ask a rhetorical question. Can a baby be addicted to drugs? And I'm just going to tell you the answer is no, right? Because addiction is a response to these long-term chemical changes in the brain. A baby is not making a choice to use or not use drugs. A baby is not addicted. Can a baby be born dependent on a drug and have withdrawal symptoms when the drug is removed? Absolutely. That happens with antidepressants, with blood pressure medications, with other drugs that we'll talk about in a minute. But I'm going to tell you a story about a couple babies who were born addicted to drugs. Amber was born in 2000. Her mom injected a large quantity of drugs 4 or 5 times a day. During the course of the pregnancy, mom was hospitalized twice for overdose. When Amber was born, she was lethargic, irritable, she fed poorly, she required ICU placement for 4 days, medical management every 2 hours of life for the first few days of her life. Some of you will look at this and you'll have some level or sympathy or empathy for how bad this process was for both Amber and her mother. And you'll be able to see them both as victims, or at least people who suffered equally. Some of you will look at this and you'll think, that stupid woman who got pregnant and didn't care about her baby and allowed this to happen. And some of you will have some mix of both those feelings, right? Because this is a complicated subject, it's hard. Because this is what women of childbearing age do. Amber's mother got pregnant again a couple years later. And it was worse this time. Injecting even larger quantities of drugs 6 to 7 times a day, 3 hospital admissions, and 1 near-fatal event at home. And this baby actually came early, lungs were not mature, required respiratory support, IV placement. For those of you who don't work in a hospital, watching them stick IVs in a baby's head because they can't access lines anywhere else is painful. I know, because those are my babies. And the disease that I had was not substance use disorder, thankfully, but I had diabetes. I had actually really severe diabetes during my pregnancy. And the funny thing is that even though I actually became unconscious and seized at home by myself while pregnant with my second child, with a 3-year-old left at home unsupervised, nobody ever even considered the possibility that I was an unfit mother because of my disease or that they should report me to child welfare services. Nobody told me if I hadn't had those tortilla chips at lunch, I wouldn't have screwed up my sugar so bad that day that I actually went into crisis. Nobody ever said those things to me, right? What they said to me was, this is hard. You have a disease that's difficult to manage during pregnancy. Your babies will likely require some additional medical care after they're born because of the consequences of your disease. And it's okay, because we can help treat you, we can do things to help keep you safe, we can do things to treat your babies after they're born, and you can be all right, they can be all right, right? This is what we do for women who have diabetes. It's what we do for women who have hypertension. It's what we do for women who have thyroid problems. It's what we do for women who have depression or other mental health problems while they're pregnant. This is not, as a whole, what we do for substance use disorder in women who are pregnant. The question is why? And the answer is really quite simple, because no matter what the science tells us, most of us can't fully accept that this is a chronic disease, right? We still view it as a choice, a moral failing. So this is a much younger version of me. But treating substance use during pregnancy is no harder and no easier than treating any other chronic disease. It requires a mix of evidence-based treatment for the disease itself, compassionate, practical support for the parents and family who are going through this situation, care that focuses on the well-being of the mother-infant dyad, that combination and pair, and prioritizing non-pharmacologic interventions where we can. Now, that does not mean not offering medication to mother. That means not turning the consequences of mom's disease into a crisis. Babies who are born to mothers who have chronic diseases are going to have additional health problems when they're delivered. They just are, because mom has a chronic disease and baby was exposed to that. Is it the end of the world? Does it mean mom did a bad job? Does it mean she didn't take care of her disease or she didn't try? No, it absolutely doesn't. It is a natural consequence of a woman who has a chronic disease being pregnant, a very stressful state on the body, and giving birth, a very stressful process for the baby. So I'm going to cover just a couple of science-y things. Can somebody time check me? How much longer do I have?
You're done.
Okay, so so just a couple of science-y based things to drive this point home in case anybody has questions. If we're talking about opioid use disorder, which is not the only substance use disorder that we deal with, but if we're talking about it, there is no excuse for anybody in this room not supporting medication-based therapy. It is the standard of care. To try and talk women out of it is malpractice and is criminally liable, because we know that detoxing people and not treating them leads to an 80% failure rate over a 30-day period. For you to recommend a treatment that has an 80% failure rate / risk of death over a 30-day period when there are treatments that have 60, 70% success rates available is criminally negligent, right? We know that with methamphetamine addiction, the best treatment option that we have right now available, the science tells us our most effective treatment is something called contingency management. I won't spend a lot of time on this, but I'll say it because a lot of places consider this like, why should we just pay people not to use drugs? That is way oversimplifying what's happening here. And if you don't understand or know what this is, you need to get some education about this, because right now, this is the most effective treatment that we have for people who have stimulant use disorders. We need to look at the way we handle infants who experience withdrawal when they are born, right? Because the process that many places currently use, where we take those babies away from mom, we put them in the NICU, right? If you want to ask me, how do I make a baby cranky and irritable? I'm going to take all its clothes off, put it in a brightly lit place where no one's interacting with it and there's a lot of movement and a lot of noise. That is a recipe book for how you make babies irritable. Now, how do we assess withdrawal in a newborn? In large part by how irritable they are, right? So we're making babies irritable by taking away all of the things that comfort them and soothe them and increasing their expression of withdrawal by doing that. And we're separating them from mom, which is creating a crisis for both the baby and the mom, which makes the mom less likely to be able to keep stable in her disease process, right? So we're creating this self-fulfilling prophecy when we do this. Eat, Sleep, Console is really the new methodology that is the standard of care in treating babies who are affected by withdrawal. Because honestly, if any of you have ever gone through surgery or had any kind of acutely traumatic event in your life, I can make anybody look better by dosing them with opioids. You're hungry, you're cranky, you're tired, you're sad, you're sleepy, and you're recovering from a surgical procedure, and you're giving me a grief on the floor as a nurse. Like, I'm gonna give you a dose of pain pills. You're gonna at least seem like you feel better because you're not gonna be bugging me as much, right? So do some babies require opioids as part of that taper process? Yes, some do. But most actually don't. Most can be managed with non-pharmacologic measures. And doing that and supporting mom in that actually really helps her learn how to bond with and treat her baby so that they're more likely to be successful when they do leave the hospital, which is something that we would be all in for if we actually approach this with the idea that the ideal situation, when possible, is for baby always to leave with mom. And then we tend to kind of start pulling back services at about 6 months after pregnancy, after delivery. We're like, yeah, you're stable, you got this. We quit watching quite so close. That is a mistake because relapse rates are actually highest and risk of death and overdose is actually highest between 6 and 12 months after delivery. And that makes sense. Your hormones levels are starting to shift again. You're starting to lose some of the tighter supports that you've had during the pregnancy process. Your baby's getting a little harder to care for because they're starting to move around and require more than just holding them, right? So our programs tend to actually stop the intensive management somewhere between 6 and 12 months, but it's really important that we understand this is the highest risk time of death for mom and that we're really doubling down during those times and not backing off because we think we got this licked. Because this is a chronic disease, right? Not something we just cured. And then my last and most important, no one should be treated like they don't have a right to have a child just because they have a chronic disease. However, most pregnancies, I'm sorry, at least a third of you, more if your parents drank or used drugs, were accidents, right? So most pregnancies are accidents. We don't have a very good system of actually ensuring access to adequate contraception for women. So all women should be assessed for their desire for pregnancy or not and should be offered supportive treatment that's in line with their wishes. And if that's no pregnancy, get them on a LARC, get them on a long-acting reversible contraceptive. If it is somebody who has a substance use disorder or some other chronic disease and is desiring pregnancy, then talk to them about the risks and benefits of getting their disease under better control before they get to that point and the type of management they're going to need to help make them as safe as possible during pregnancy. And then check your biases. How many of you have ever called to report a mom to CWS because she or dad smoke? You're just going to send that baby home with somebody who smokes? You're not worried about that? Do you know how many babies die from SIDS, from cigarette exposure? Like, no joke, way more than are affected by drug use. How many of you, just off the bat, not because of activities or behaviors, have said, hey, I know dad in that family drinks a little bit too much, we need to call and report them? The data shows us that even though we're more likely to file cases and remove children from women who use methamphetamines, that children are more likely to suffer physical abuse in a household where dad uses alcohol, right? But we don't care because we're not as judgy about fathering as we are about mothering because we don't see the effects of it in the NICU when they're born. So we need to actually make sure that when we're responding to these things, we're checking them against our biases and against the actual numbers of what those risks are and not just our perceptions of what risks are. Because this is not a newborn, right? It's not just a newborn. This is a person who, with any luck, will have a full spectrum of life. They will be a toddler. They will be a teenager, they will be a young adult, they will be a grandparent someday. And we cannot afford to treat them as if that 2 days or 7 day or 1 year window at the beginning of their life is the only part of their life. And we know when we remove children from their families, and I know sometimes there is no other option. Trust me, I know sometimes there's no other option. But when we remove children from their families, we start this cascade of events that has an effect on their entire life. And 70-year-olds still don't make good choices and take care of their diabetes because of the trauma that they experience in these early stages of their life through that process. And if we turned our efforts around and we invested even half of what we spend on the disciplinary and repair side on stabilizing families and giving them the support they need to be able to raise their own children, that we would ultimately have better outcomes. And we can't afford to miss that, because these kids, they are our future, and they are the future of our community, and we owe it to them and to ourselves to make sure that the future they inherit is better than what we have right now. Thank you.
We'll just talk before they introduce themselves, but I want to just reiterate that First by Shasta is really interested in the work that's happening in the community so that we can find where we might be able to support any gaps or barriers in services, and also to make sure that the right people are hearing the information that need to hear the information. And many of you in this room have that similar mission and vision, and we appreciate all of the hard effort that's going into working toward helping women who are in recovery and may need a little bit more assistance, and may need a little bit more support, and maybe different support than we've been seeing from the past. And so as we continue to work through some of the wonderful things that are back there posted, we are definitely on our way. So I think that it's great to have all of you here talking to one another, getting great ideas down on paper. So again, thank you to Public Health for making this happen, and Amy Pendergast and her team, who have been the forefront and runners in this for this event to happen. So again, thank you. I'm going to moderate some of the questions, but each of them are going to have a few minutes, just so everyone knows what's going to happen at this point. Each of them are going to tell you a little bit about their journey in the work with women who are in recovery, and some of the things that they're passionate about in this work, and really what that work looks like. And then I have a few questions that I'm going to ask, and then hopefully we'll have some time at the end that we might be able to field a couple of the questions. With that, I'm going to leave it to Chris to introduce herself first, and then we can just go down the line.
Okay, well, I'm Chris Thunberg, and I work at Women's Recovery and Resiliency Services, and I'm a counselor there. We're considered social workers. I'm very nervous. I'll let you know right up front.
Doing great.
So, let's see, my certification, I'm an alcohol and drug counselor. I have a certification, KDAC and CAS 2, and I've been working in the field for 22 years at the same place. And my passion is definitely women with.
Sorry.
You know, that's okay.
I can't hear you.
I was wondering, it's like,
I'm hearing myself.
yeah. Women who are pregnant, and just women with drug and alcohol. Women with drug and alcohol problems. Definitely, it's been my passion. I have experience with that, personal experience. I have a daughter who is 32, and fortunately she has never really had to see me drink. I will share with you that I did drink while I was pregnant with her. I have a 2-year-old grandson, and he is the light of my life. So that's about my introduction, and I didn't go 20 minutes like I did before. So the focus of my work. I work at a program that is 4 hours a day, 3 hours a day, 4 days a week, and so it's an intensive outpatient program. We have childcare, we have transportation, and so, you know, in the 23 years that I've been there, I've seen a lot of the positives and a lot of the negatives. I have seen successes, and I have seen people who just aren't there yet. You know, I think that each and every woman and man have the ability to get there. I think there are a lot of services that each person needs, and I hope that we can meet those needs. That's kind of my passion, and the reason that I came here today to hear all of the resources, you know, and I'm hearing so much today. So I guess that's what I'm seeing in the community, and I want to keep seeing more. And I think that there are a lot of resources out there that we can all use. So I think I got that right.
You did.
Thank
great.
you.
You did great. Thank you.
Your turn.
Can you hear me? Hi everyone, I'm Courtney Stone from Aegis Treatment Centers. I am a lead counselor there, and I wear several different hats. I train and supervise the counselors. I was a counselor for a while myself as well, and we're starting to do groups, which I'm taking the helm at starting and kind of formulating that whole thing and watching how it turns out and praying that it works out well for everyone involved. But yeah, I pretty much, that's what I do. I'm very hands-on with the patients when I can be. I think it's really important for them to have a sense of community and a place where they can go and feel like they're not alone. And so that's kind of what my personal little mission has been in this whole thing, you know, just being the squeaky wheel and getting us back to that community-based place that we should still be. So that's what I do with Aegis. About myself, nothing crazy or exciting or anything. I haven't been in this field for terribly long, and I don't have personal firsthand experience with substance abuse, but I grew up in a family where it was very prevalent on both sides, my mom and my dad. And I got to see a really wonderful, wonderful example, two actually, of people with ACE scores that are off the charts and come from terrible situations in homes who decided to break that cycle and to give their kids a loving home and a safe place. And so I feel like that was something that really showed me that there are people out there who can be so helpful and who don't have to be a firsthand, user, and that's okay. And just because, we don't have experience with actual using drugs doesn't mean that we can't be beneficial and supportive, because, people who have substance use disorders, they are people and they have a disease, and they just need people who love them and see them and respect them. So that's where I'm at with that. I would say that what I'm seeing most in the community is with, as it pertains to pregnant women who struggle with substance abuse disorder, is probably they're scared, fear. I'm noticing a lot of women are afraid to even go to their primary care doctor because immediately CPS is just thrown right at them, and they're afraid that if they go to the hospital, their baby will be taken, which, isn't completely something they shouldn't think about if they're using, but also it's scary to know that that's something that could happen. They're afraid to reach out for help. And a lot of the times I see women who come into treatment for the first time in their second or third trimester, and that's not soon enough, and it's because they're afraid. So I think kind of removing some of that negative mindset about women who are hoping to reach out and get help, I think that would be super beneficial in trying to reduce babies who are born in these types of situations. So, yeah. welcome to my speech.
Well done.
Thank you.
Dr. Pat.
Yeah. I kind of feel like I want to walk around with this Bob Barker microphone. Ask you all for bids. What's your bid? Well, my name's Kyle Patton. I'm a family medicine doctor by training. I'm also a street medicine doc with the HOPE program at Shasta Community Health Center. Let me ask, how many of you are familiar with kind of the concept or field of street medicine? A lot of us have kind of heard of it or seen providers doing it in the news or that sort of thing. Good. Okay. So street medicine. So my practice is 100% mobile. I don't do any brick and mortar. It says on here Hope Van. Really, when you think of Hope, we're a service line that cares for patients experiencing homelessness within Shasta Community Health Center. So historically, we have been synonymous with the Hope Van. That's a mobile medical van that we park at fixed sites around the city. But we also do more than that. So we do street outreach to camps. I'm currently the only full-time medical provider doing street outreach. I do that 2.5 days a week. We also do medical respite, which is a post-hospitalization program for patients experiencing homelessness that are getting out of the hospital, and also for patients that I identify out at the camps that may have an acute medical issue where we're trying to get them in somewhere stable so that we can then kind of hustle and subsequently prevent a hospitalization, right? So when you think of Hope, right, yes, we're the van and we've been that historically, but now we have, various programs where we're trying to strengthen that safety net so that we can provide our patients that are unsheltered with a little bit more support. Kind of a little bit about myself. So I kind of fell into this. I had some time off between when I graduated with my undergrad and when I was going to medical school. I'm from Salt Lake City in Utah, and I took a job, just kind of fell into it with a nonprofit as a homeless outreach worker. And as part of that job, I would drive around the city in a really cool maroon van, handing out, basic need items, sleeping bags, hygiene kits, clothes, food, that sort of thing. And the whole idea behind my job was to build rapport with folks and then be a bridge to various services. So as part of that job, I worked with a PA who was doing full-time street medical outreach with the homeless clinic, the FQHC there in Salt Lake City. And so then that was where I really caught the bug and said, this is what I want my practice to look like. So, I'm one of the first, not to brag, one of the early street medicine physicians that's actually been trained in street medicine. So I did an extra non-accredited 4th year with my family medicine residency that was focused in street medicine, where I worked with my mentor who helped me kind of build out an educational track. So, street medicine has this really super cool grassroots history where, providers were leaving the clinics and hospital and out there, providing care on the street. My generation of street medicine doc is now trying to figure out how to make that a viable delivery model within healthcare. And so that's kind of where we're at. And it's moving forward in California. There's now money that goes into street medicine. The Department of Healthcare Services has now said that all the managed care organizations in California need to contract with a street medicine program. So you're going to start to see this as a model of care kind of more and more. So really it was, I'm trained in OB care. I'm not an obstetrician. I do like, maternal care. It historically hadn't been a big part of my practice, but, in street medicine, there's kind of this adage that gets run around, which is let the streets be your guide. So really what that means is that our practice on the street is informing us really more so than what we're informing or educating our patients on. So it really, when I came here 3 years ago, I started doing street outreach and I started going out to camps, building trust with folks. And it just started to be patients saying, hey, really, Patton, you got to walk down the trail. You got to go to this camp because so-and-so, there's a pregnant girl down there. There's now, there's a pregnant girl there. there was a lot of pregnant girls when I started seeing them, a couple of years ago. And it really has become a big part of my practice and a big part of what we do within our Hope department. So the majority of the care that I provide for women on the street is done out at the camps. We do, when we're able to, based off of our funding, we do try to get them into a motel or a group home setting where we then have them in a stable place, right? Because we know that homelessness is not only going to impact like their perinatal outcomes, but also their ability to access care, right? So, but if we're not able to do that, if all the care that we can provide is on the street, we're going to do that. And there's actually a lot that we can do. So what that looks like in practice is me making contact with that patient. They can provide a urine at their camp in a cup. I dip it with the HCG strip. We confirm their pregnancy. If they're early on in their pregnancy, I can do an ultrasound. I carry a little handheld ultrasound that plugs right into my phone. I do measurements so that we can then nail down, confirm their dating, and then that's really helpful going forward within their pregnancy. It used to be that I was catching women later on in their pregnancy, like 27, 28, 29, 30 weeks. I'm subsequently now involved in second pregnancies of women that I managed, a year and a half ago, which, with those women, they're now contacting me very early on, and we're getting them at, 7, 8, 9 weeks. So that speaks to being out there, having a presence, providing women with care. Really in street medicine, we're trying to play that long game. And so it's a lot of harm reduction focus, it's relational, so that even if you catch them late on that first pregnancy, we try to prevent the second, but it doesn't always work. At least they're then engaged with you and we can funnel them into care, much sooner. So as part of, with patients that are unsheltered, we talk about this idea of trimorbidity. That's, this idea of three various, it's kind of a Venn diagram of chronic disease, behavioral health, and substance use kind of coming together. And we know that patients that are unsheltered living on the street deal with high rates of trimorbidity. And it's the same thing in our pregnant women. So a lot of them have very high-risk pregnancies because of that kind of coalescing of various risk factors. And so we really try to be cognizant of those women that are unsheltered living on the street. We provide as much care as they're able to allow us to. We try to get them connected with our maternity center. We try to get them, connected with brick and mortar systems because that's going to be the bridge to the hospital. They're going to be able to do a little bit more than what we're able to do on the street. But even if it's a woman where I'm able to check her blood pressure at frequent intervals, doing syphilis screening, which is, as we all know, is very important, right? Rates of congenital syphilis in California are through the roof. And, in my mind, that really is like a sentinel event, something that's really important for us to be active in preventing. So, I think, I didn't anticipate that this would be a big part of my practice, but as I've grown as a provider out on the street, and as our department's grown, we've really then been able to not only engage with these women and get them connected with care, but we've been able as a department to beef up our own abilities out on the street and provide robust maternal care with a surprising degree of quality. So that's us. That's Hope. We do a lot of MAT. We do harm reduction teaching. We manage the Suboxone for a lot of our pregnant women. And then we also provide a lot of kind of social support, case management, that sort of thing. So yeah, that's me. I think I'm maybe went over, so sorry.
That's good. Thank you. I know, you do feel like Bob Barker, right?
You do, totally.
My name is Amy Ross, and I'm a case manager and a lactation specialist for Pathways to Hope for Children, for their, also known as the Parent Partner Program. I work in the Road to Resilience program, which serves mothers who are pregnant up to 6 months postpartum who have ever used substances. So it's a wide range of use, whether it was in their past, present. So I work with women in different stages of that. I'm a single mom to an 11-year-old little boy who keeps me on my toes. My educational background's in child development, and I use that education to teach preschool for the better part of my 20s. When it was time to start my own family, I thought I knew what I was doing because of that, and I quickly realized that I did not know what I was doing. I used to want to have 4 kids, And then I had one, and I was like, I think we're good. Because the reality of what being a mother really looked like really hit me like a ton of bricks. And that journey is what led me to work with addicted mothers. Before I had my son at 30, I was really independent, career-minded, and I thought that somehow when I had my baby, I was going to magically transform into my very successful housewife grandmother, and that did not happen. I realized that, I also thought that my lifelong mental health challenges were just going to poof, and I was going to be great, and I was going to rock this mom gig and not have any problems. Started off pretty well, had a pregnancy without any complications. I exclusively breastfed my kid until toddlerhood. Did all the little cute little things on Pinterest, the little arts and crafts and what have you. Overcome postpartum anxiety and PTSD after a tragic loss. But I soon realized that I didn't know myself anymore. I had become this mom bot, this robot that was programmed to take care of everyone else's needs except for my own. And I stopped caring about my physical appearance. I stopped socializing outside of my phone. And my house was a hot mess. But, we were making memories. It was good, right? Because the world expects mothers to leave themselves behind and focus solely on their children. Doing it all and doing it well. So I had a great social media front where it looked like I was doing real good, but underneath things were not stable. When my son was in kindergarten, I found something new. The first time I used cocaine was at a barbecue on a whim. I thought, I'm grown, this is fine, it's gonna be a one-time thing. That one-time thing quickly grabbed me, and before I knew it, I was almost 2 years into using every weekend and sometimes on Tuesdays. But because I wasn't destitute, I wasn't using every day, I didn't think I had a problem. There's nobody in my family that isn't addicted to something. So I've been raised by addicts, but most of them are functional. They held jobs, they made it happen. So I didn't think that it was a problem. But I don't remember my son's 7th birthday. I don't remember when he got too big to pick up. And I would sleep most of the weekend away, go out Friday, Saturday night, sometimes Sunday night, and my now ex-husband, not because of that, but, would pick up the slack. And my use was the biggest secret I kept from the world. This April, I celebrate 3 years clean from cocaine, but I never thought I would be an addict. I never planned to be an addict, but it spoke these magic words that unlocked pieces of me that I couldn't access because of past trauma, mental struggles, things like that. When I was using, I was confident. My house was clean. I could practically hold court when I went out. I was always the life of the party. At work, I was successful. I was holding it down. I was great at my job. But deep inside me, I was without an identity outside of my motherhood and my career. And I believe that loss of self, mixed with the trauma I experienced as a child and as an adult, really led to that addiction. I started using well after I was pregnant, but I could have easily been one of the addicted women that are on my caseload, had the circumstances of when I started using been different. The mothers I work with are using substances during pregnancy. The women I work with who are using substances during pregnancy aren't doing it because they don't care about their babies. They aren't doing it because they think it's fun and reckless. If you've never been there, it might look like that, but that's not the reality. They're using drugs because they're hurting, and drugs are helping them survive some version of mental anguish that they deal with every day. The most addicted mothers I work with are either on the street or 1 to 2 steps away from being on the street. They're often victims of emotional, psychological, financial abuse, domestic violence. They were traumatized as children. They're often raised by addicts or in foster care. And even the mothers I see that are using less stigmatized substances like cannabis are usually using it to self-medicate for some other issue that they're having. But when someone finds out that a mother is using substances while she is pregnant, the witch hunt has already begun. She's also often paralyzed by fear of finding herself in trouble instead of finding help during a pivotal time of change. And I see that a lot. I see that a lot where moms are just too afraid of the stigma, too afraid of the judgment, too afraid of losing their babies, too afraid of what could happen because of the disease that they have. Often multiple diseases. A study showed that when you educate a woman on breastfeeding, that if you focus solely on the baby and what's good for the baby, it's not as beneficial as if you also focus on what is good for the mother. And we need to do that across the board. The idea that we have as a society that women, once a woman gets pregnant, that she must abandon all other endeavors and her life is no longer her own, is really toxic. We are not mom robots. We are people too. And then expecting an already addicted woman with a laundry list of other challenges to just wake up one day magically well because she's pregnant is frankly absurd. The stigma is the biggest barrier that women face when accessing actual help they need. Ending substance exposure during pregnancy starts with remembering that mothers are humans too. And sometimes humans are messy and they need non-judgmental help to clean up. Thank you.
Thank you. Thanks for sharing. All right. Kimberly.
All right, my name is Kim McKinney-Tai. Hello. I just want to start off by saying that I'm really grateful to be here in a room such as this, you know, with people that have such diverse experience, and what a rich learning experience this is for me today. I by no means consider myself a specialist in prenatal substance abuse treatment or care, but I do have some experience, and I'll tell you a little bit about what that is. Currently, I work as a clinical program coordinator for Health and Human Services Agency. I am a licensed marriage and family therapist, a substance use disorder certified counselor, and a professor teaching in the MACP program at Simpson University. I teach substance abuse and co-occurring disorders for people that want to be therapists. I oversee 6 programs at HHSA. So the 2 collaborative court programs that I oversee are the Addicted Offender Program and the Behavioral Health Court Program. I also oversee the clinical services at the Probation Department at the Community Corrections Center. The Access SUD counselor, I oversee her and those functions. A team of recovery coaches, and a new program, our core program, which is co-occurring recovery engagement. That's designed to serve people with an SUD disorder and and not necessarily a mental health disorder, but moderate to severe mental health symptoms. So I do have 22 years experience in SUD treatment, specifically in residential treatment, outpatient treatment, and those that are connected with the criminal justice system, which is my absolute favorite. And then the next part of what I'm going to tell you about me, it is interesting that the experience that I had physically when I was making these notes. The next part, I have a little bit of resistance, and I come up against what I call a screen, because it's no longer a wall, but it's a screen. A short screen, so I can climb over it or whatever, go through the whatever. But I have lived experience with prenatal substance use. And so stigma is the reason why I don't want to tell you that. And hopefully, like today, one of the things that not just today, but today and forevermore, I'm hoping that that is what we can battle. I remember being at a conference, and I think it was the Surgeon General of the United States said, drugs and alcohol do not kill people, stigma kills people. And I would venture to say that today we can agree that stigma hurts babies. So I totally agree with that statement, but I just went through the screen, and I'm telling you that I am a woman that used while I was pregnant. I used meth in my early pregnancy, and I used marijuana in my middle and late pregnancy. That still to this day, after 26 years of recovery, brings a knot to my throat. And I've done a lot of work. I've done a lot of work in my recovery, a lot of work on my mental health, and it still brings that. I can tell you that, you know, as a woman that was doing that, I was filled with shame and fear specifically fear of judgment. And it wasn't as horrific when I was under the influence as it was horrific facing that in early recovery. Because take away the biggest coping skill that I had my hands on, which is drugs and alcohol, I'm left with all the feelings that I could numb with substances. So that early recovery time is just kind of filled with all that stuff, right? Also, what I can tell you is that baby and that experience, motherhood, has been the driving motivation in my recovery since the very beginning. So the incomprehensible demoralization that I felt as a using mother became my biggest why in recovery. And so I think, I don't know, we might be onto something there. Just knowing that babies change people, or they have the ability to change people. So I have lived experience with recovery as well, and I'm hoping today that we can really talk about great solutions and bring all of our minds together and all of our different viewpoints and lenses to come up with like real solution in our community. I just heard about in the work with my recovery coaches. We just got wind at a phone call from somebody who has a friend who's using drugs and is living under the bridge. And so I'm really grateful that Dr. Patton is there. And I'm really grateful that we got the call, because recovery coaches heading down under the bridge to meet this gal is amazing to me. Like my Katie says, we got to get out of the box. We got to get out of the boxes that we've put ourselves in. And I think that together we could do that. So thank you for listening.
Wow, already so much information, and billions of questions in my head already, I'm sure for all of you as well. This is definitely going to be some interesting information, and I really appreciate all of you for sharing what you've already shared. I think one of the big things, I personally, and I know that when I've had conversations with other people, we'd like to hear from you, is what are you seeing as the big, the challenges for some of these women who are pregnant and they're, trying to get into recovery or are in recovery? What are those big challenges that they're trying to overcome that are almost insurmountable?
Relationships.
So tell me a little more about that. What does that mean?
So I can tell you from my personal experience, and professional experience, the boyfriends, they hold us in the world, in that space. I feel like to leave all that we ever know to try something, or to enter into a world that we can't even imagine is almost insurmountable, to a person. So, I think that, and relationships kind of bring us back into the environments that we came from. Those are sometimes really strong connections. I know that, like in recovery, I'll hear people say, oh, you know what, those people out there, they're not your friends. And what I can tell you is that it sure does feel like they're your friends. It feels like that's the only support I know, and the only support that I can really depend upon. So that's what I meant by relationships.
Great.
I think support systems, to kind of piggyback on that, is a huge one. A lot of women who are struggling with substance use and during pregnancy just lack support system and community, and they have maybe only that boyfriend, and that's it. And then to go along with that, transportation. At Aegis, we find that one of the biggest hurdles for anyone, not just pregnant women, in order to get to treatment, is their transportation. Just getting there is a battle every single day. And that goes along with the whole relationships thing, so it all kind of ties together.
I think basic needs being met, some of those were talked about, and for us, we supply childcare and transportation, which is great, but not everybody can do that. you know, supplying bus passes, and I know that some agencies are able to do that, and it's really helpful. Yeah, so basic needs, you know, housing, it's great, some people can get it, but some people fall into that place of you don't qualify, you know, and so what do we do about that? Making sure everybody qualifies for, you know, to meet their needs.
Yeah, I mean, to kind of build on that, sorry, I didn't mean to, yeah. To kind of build on that, you know, I went and checked on one of my pregnant gals this week, who's 28 weeks, she's unsheltered, and as all of us know, we had snow here in Reading this past week, so, you know, I went out to the camp. She's obviously focused on different things than her prenatal care. It's, you know, it's that Maslow's hierarchy of needs, right? Like, it's snowing, she's in a tent, her bedding's all wet. It seems ridiculous for me to go out and say, like, well, are you taking your prenatal vitamin? You know, like, as she's headed to the laundromat in the cold to, like, you know, like, dry out her bedding. So, you know, I think understanding the social context, right? You know, we talk in medicine about the social determinants of health, but, you know, do we really understand? You know, we want the patient, we want to, like, have the patient continue to reach that gold standard of medical care while we're also thinking about the social determinants of health. But I think, you know, in our department, we don't, you know, compliance, we don't talk about compliance, we talk about providing patients with support. And I think that's the kind of tone that we need to have when we're approaching patients in these situations.
Excuse me. I think accessing services can be really confusing for people, you know, especially people on the street. You hear, oh, my friend says I don't qualify for this. My friend says, oh, I don't qualify for that. And you kind of like take that and run with it. And I think, you know, helping them access those services, the Parent Partner Program help with that, and kind of just even help fill out the paperwork that can be really confusing, or pick up that phone and make that appointment, because we all have probably all heard the 10,000 pound phone, you know, making that first call. I don't know what it is about it that it's so hard, but it can be hard. And so having support in that and someone that knows how to access it is important.
To piggyback on that, something like you said, picking up the phone and making that first call, that's like the hardest part right there. And to add on to it, if these women are pregnant and they're afraid, you know, of seeking help because of what could possibly happen, the amount of time that it takes once you do pick up that phone and call someone to actually access a service, to actually get a hold of someone, you have to leave a message with a callback number and always have your phone charged so someone can call you back, and then you have to call them back again. So it's just getting these services quicker and having them easily accessible is kind of key, because they're going to make that first initial step, but we're not going to be there to meet them, you know. So once that changes, I feel like people will be a lot less afraid to make the call, because they know they're not just leaving a message at someone's machine, you know.
That was a great segue into a little bit more of what then are the elements leading to success. So you kind of mentioned, you know, having it available once they've made the choice that they can take that step, right? Once they realize it might be something they can do. What are some other things for women that will help them lead to that success?
I think, to piggyback again, I think that having some sort of system in place where when they're ready to make that call, that someone is available to answer it or get them immediately into treatment. I know so many addicts that, oh, I'm ready to go to rehab today, but then they have to wait, and then they fall off the planet between those times. So some way to bridge that gap is really something that we need.
So speaking of bridging the gap, I don't know, maybe a couple years ago, UC Berkeley came up and asked a bunch of, utilizers of service and myself to be part of a listening circle. And they did like this really cool thing where we sat in a circle and they asked a bunch of questions, and all these clients participated in answering questions. And really they were trying to, figure out like how could we bridge gaps. And, what came out of that was across the board, whether it was a mental health client or whether it was an SUD client, all of them said it would be really, really nice to have their person, to have a person that would walk with them from one part of the system to the next and be with them, because they meet, we meet so many people. I've worked at HHSA for 12 years and I can't even remember everybody's name. I don't even know who's who. And I can't imagine being, freshly clean and sober, trying to remember the names and remember the appointments and doing all the things, and it's overwhelming. So I think that peer support specialists and recovery coaches really help in that way, and we need 5 million more of them to really grab people and walk with them to help them not get lost. What do we do while we're waiting for a bed? Yes, we need more beds, but I feel like that we're going to be waiting for beds, we're going to be waiting for slots, we're going to be waiting for appointments. What do we do in the interim? And I think that recovery coaches can possibly help with that, and peer support specialists.
I think, defining success for my patients, it's always a moving target. I try to think less in terms of success and more in terms of minimizing harms, both to mom and baby. An example of that is I have a woman who just delivered, and she was positive for gonorrhea chlamydia in her kind of late second trimester. So we were able to, not only get her tested in the field, but get her treated, and then have a negative test of cure. So that's a very clear minimization of harm for both mom and baby. So that's a success right there. Same thing with our syphilis screening or getting moms engaged in MAT and other substance use treatments, irrespective of whether they're fully on that road to recovery or not. I think that's, we try to take a harm reduction approach. I tell the residents, I work with the family medicine residents, and they come out with me on the street, and I always tell them, hey, here's the gold standard of medical or maternal care. Here's doing nothing, and then here's where we live. We're always in the gray. And in any given situation, you sort of have to ask yourself as a physician or a medical provider, what am I able to do today for this patient, given some of their barriers and limitations?
On that, I tend to think of the full circle. Tending to have more people involved in one person's care. Well, like the young lady you were talking about, with our women, we try to, and I hate to just narrow out our women, but having them exposed, say going to the doctor or whatever, to various agencies, say Planned Parenthood, places like that, at the doctor or whatever, to help with situations like that. Having a woman identified as having, syphilis or whatever, and being treated for that. Having those things available so that they have the knowledge, and bringing the knowledge to them. I probably went off topic, but.
No, I think you're fine.
Okay.
I think you're fine. I think, what I'm hearing is that we really do need to meet the person where they're at. And the success may look different for each of them based on where they're at and
True.
what we can help provide. But that we need to make sure we're providing it and that we're giving them the information to know where to access it.
Yeah. And all women, not just, I'm going to treat you, but here's some other options as well. Yeah.
Great. Did you have anything you wanted to add?
Yeah, I was just keys to success, something that I think is very, very important, and something I've kind of gotten a little bit more, just since this whole situation has been going on, a little bit more aware of is treatment for pregnant women tend to be, it's for some reason kind of clumped in with all of the other treatment, at least at our clinic. That's kind of how it looked from the outside. They're all just clumped in with everyone else, when in the end they should have much different care than, just everybody else. And I think really close follow-up is very important, weekly, even more than that. And then, just assessing their individual needs rather than just this group as a whole, I think is really important. That's all.
I'm looking toward my timekeeper. Do we have a few more minutes? Or?
Yeah.
All right, great. All right, so I wanted to go back to something that a couple of you have mentioned. I think that Kimberly and Amy both kind of mentioned the fact that there's sometimes a stigma. So I want to maybe see what you all think about when you hear that word. What is it specifically identifying in your minds when working with this population, the stigmas that they're trying to overcome, having put upon them, or that you're hearing from other people that you wish would go away?
I think Dr. Stockton actually illustrated it very well. Putting her babies up there and talking about this mother that's injecting drugs and and taking a look at how substance use disorder and mental health disorder, those disorders are often co-occurring and they're real. I think that our community as a whole doesn't look at that the same way as a physical ailment, and that stigma needs to be broken. We're doing a good job at working on that, but we need more of that solution. We need more of that normalization that, hey, this is a disease. This is something that needs to be treated. And that part of the stigma needs to go.
Yeah, and that it's not you're not a bad person. That
Yeah.
And Dr. Stockton said, it's a disease. It's like cancer, and there's no cure, but you can manage it, and for people who haven't experienced it, helping them understand that, and finding a way to do that. And in our program, we had some intern doctors from Mercy come into our program and listen to the women and get to know who they are, and it was wonderful, just being able to do that, to educate the community. And sometimes it helps, sometimes it doesn't. So awareness.
Do you feel like they have stigmas of their own that they need to work on themselves?
Probably. I think when you're talking about stigma, I feel like we're looking at a lot of different mindsets, right? We have progressive, we have, these conservative old school mindsets that aren't changing anytime soon. But in the end, I think rather than trying to remove the stigma from substance abuse or from using while you're pregnant, right? I think it should be more so teaching these people, educating all of these people, everybody, about what addiction is, right? And then also, furthermore, we're not going to change their mind. We're not going to, old dogs, new tricks. We're not going to change their minds. So just teaching them and showing them that these are people, and by shaming them, it is not resolving the issue. By pretending it doesn't exist is not reducing the amount of substance abuse while pregnant. It's just not. So that's all.
Yes, Dr. Penn.
Yeah, I don't want to. Do you want to go ahead?
Oh, no, go ahead.
Oh, well. I don't want to talk about, I think there's not anything I can add to the discussion about stigma that everyone's already shared and beautifully described through their own lived experience. What I will say is with my patients, I do observe a lot of institutional trauma, and I try to be cognizant of that when I'm meeting new patients that may be pregnant. What do I represent as a doctor that's now coming into their camp, and what kind of emotions and trauma does that bring up for these women? And so, if there's someone that doesn't want to engage with us right off the bat, that's okay. We're not assuming she doesn't care about her pregnancy or want to engage in care. We're just going to loop back around. It's not a good time. So, I think that's, for those of us that do work in healthcare, that institutional trauma is real, and we need to own that from our side, and figure out ways to, inform our practice with that, as the context.
And I just kind of wanted to say that, basically there is, for the alcohol and drug addict, that there is a stigma for them as well. I know for me, the belief that they're bad people, you know, so that carries out as well. I know that my guilt and shame kept me believing that I wasn't good enough, you know, so that's something that gets carried as well in dealing with the public. So just wanted to throw that out there.
Well, thank you all very, very much for your time today and for all of your information about this very important topic. I think we are going to move into something with Miss Joy Garcia. And I'm hopeful that if we have some time, you can come and see one of them and talk to them personally. Thank you.